Vita Biotechs, an award-winning nutraceutical company. It is the first nutraceutical company to complete 50 successful years. Well Baby Multivitamin Drops is the ideal supplement formula for babies from 1 to 12 months. It contributes to normal cognitive development of babies, supports normal growth and development of bones in babies, helps to boost immunity in babies. It is an appetite enhancer, supports overall health and wellness in babies, contains no artificial colors or sweeteners. Dose: for babies from 1 to 12 months, give 0.5 ml twice daily. Vita Biotechs is proud to present the comprehensive multivitamin formula for babies aged 6 months to 4 years, Well Baby Multivitamin Liquid. It contributes to normal cognitive development of children, supports normal growth and development of bones in children, helps to boost immunity in children, provides required nutrients for picky eaters, supports overall health and wellness in children. Dose: for 6 months to 4 years, give 5 ml daily, 1 teaspoonful. Vita Biotechs has recently launched its comprehensive multivitamin formula for school-going kids aged 4 to 12 years. Contributes to normal cognitive development of children. Supports normal growth and development of bones in children. Helps to boost immunity in children. Provides required nutrients for picky eaters. Supports overall health and wellness in children. Has natural orange flavor. Dose: for 4 to 10 years, give 1 teaspoon 5 ml daily. For 11 to 12 years, give 2 teaspoons 10 ml daily.
Thank you very much. Now I would like to request all the viewers, please stay tuned. At the end of this webinar, there will be a raffle draw with 3 valuable prizes. Now I would like to request Dr. Kalpana, Dr. Diari, and Dr. Ayman Jundi to join in panel. I would like to request Dr. Kalpana, because almost 80 to 90% of the questions are answered in the talk, during the talk. I would like to request Dr. Kalpana, because Dr. Pankaj Tadeja from Al Ain, Dr. Eva, Dr. Manoj, there are some questions 80 to 90% covered in the talk. So if you start with the questions of Dr. Pankaj, so 18 to 90% is covered in the talk. Your audio, Dr. Kalpana, your...
Yes, doctor. So one of the questions that he has asked, Dr. Pankaj, I think has asked, though I could not make out, is whether G6PD test is required for nitrofurantoin use. Yes, nitrofurantoin can cause severe hemolysis in G6PD patients, so it is better to do that test. And there was another question related to the frequent cleaning of the genitalia in females. What is most important is to avoid things like bubble bath, irritants. They can cause urethritis kind of symptoms, so that is supposed to be avoided. However, it's very important to take care of the genital hygiene in babies. They have to be the young girls who are going to school nowadays at a very early age, and they have to be supervised, or cleaning has to be done by the mother. They have to be advised to clean from front to back. the importance of using non-irritant soap alternatives, the importance of drying the area, all this is very important. I think, Doctor, other than that, the questions were probably covered in the slides.
Dr. Eva
what I
was
could
asking
see.
about the antibiotic.
What is the question about?
Because Dr. Pankaj actually has asked many questions, majority of those questions
Yes,
covered. And
one of the question was also that urosepsis is not accepted by insurance as a diagnosis. So insurance
the role
companies
of
don't accept
constipation, he has asked constipation and UTI.
Constipation and UTI, it's very, very important, as I've said, that it has to be adequately looked at. Quite a few of these children with voiding dysfunction actually have bowel dysfunction, and constipation should be addressed and treated. And also in those with VUR, it is important to treat constipation. So it should be prevented, dietary advice, and if needed, laxatives have to be used.
I would like to request Dr. Diari and Dr. Ayman, what is your opinion on constipation and UTI? You see a lot of cases.
Yeah, Dr. Diari. Dr. Diari, you can.
Dr. Diari is, I think, mic is off.
I think it's frozen.
Yeah, Dr. Diari.
You can answer. Constipation and UTI. Any opinion? Dr. Diari's mic is off, huh?
You can hear me?
Yes, we can.
No, it's okay. You can hear me?
Yeah.
Yeah, good evening, everybody. Yeah, actually, constipation and UTI, they are going together. And most of the time, these are the let's say, urological causes of UTI is really constipation. So, and most of the time from the history, we bladder and let's say bowel and bladder dysfunction. And once you are treating, there are studies, once you are treating constipation, the bedwetting, the diurnal enuresis, the nocturnal enuresis, and UTI has been solved.
So
yeah, may I add? Okay, constipation causes voiding problems, and voiding problems are really very important cause of UTI. It increases residual urine, it voiding dysfunctions, bladder problems, functional bladder problems, and that leads to UTI actually. This is the relation between constipation and UTI.
Yeah, Dr. Eva, pediatric nephrology, is asking, with increasing number of ESBL UTI, there is an increased interest in oral phosphomycin for UTI treatment. This antibiotic has been also used in children as a single dose for UTI treatment.
So, yes, this was one of the oral antibiotic single use. This is supposed to be it is being used. However, the guidelines still state that if it is ESBL and sensitive to the other groups, they should be preferred, though phosphomycin may not always work. So though a good antibiotic to keep in mind, according to IDSA, it is the carbapenem still remain the #1 choice, though they, again, even among that, they say it should be judiciously used. It's quite often used, phosphomycin in adults. I think it's used more often.
Dr. Ahmad is asking, do you prescribe alkalizing medicine if urine is acidic and vice versa with antibiotic?
Well, not as a routine.
Not and Dr. Because a lot of questions are asked by Dr. Pankaj, which are asked in this about the nuclear medicine diagnostic test. I think, Dr. Kalpana, if you see those who have you have covered in the talk, so you can ignore those who really need answer with the help of our panelists, pediatric surgeons, because so many 90% of the questions are covered in your talk. I don't know if Dr. Joshi has joined us or not.
May I just comment on the isotope scan? Because
yes,
it seems, just Dr. Kalpan and Dr. Ayman, maybe your mic to be off and then not to be echo. Now, we have to differentiate between DTPA, MAC3, and EC and DMSA. Now, DTPA and EC almost out. Nobody is using them. It is mainly MAC3 and DMSA. And when we are when there is a reflux, we are usually using DMSA because this is a static and we are looking for a scar. When there is obstruction, then for a drainage, we are looking for a drainage, hydronephrosis and a drainage, then we are using the MAC3. We want to see the drainage, to see the ureter, to see the degree of hydronephrosis and where is the level of obstruction. This is the difference between DMSA as a static, not dynamic, to rule out scar and to know the function. MAC3, we can see the function, but we can also see the drainage. Yeah.
Somebody also has asked where in Dubai to do MCU. I mean, which place they are doing.
Most of the hospitals are doing MCU in their radiology departments.
Please take those questions.
Yeah, Doctor, yeah, there are a couple of questions, like there was a question on yeast cell. So yeast cell can be a contaminant. However, after proper cleaning and collection, if we do find evidence of fungal infection, we have to treat with antifungals. This was one regarding fungal infections.
Most of the fungal infections are contamination. So
Yes.
only one sample on, let's say by collection, it's not regarded as urosepsis. We have to be a little bit careful of that. There should be only yeast or candida, let's say, or yeast to diagnose it as a urosepsis. Not any urosepsis, we have to, any culture of yeast, we have to treat with for candida or for yeast.
There is a question about, it's difficult to find where to do the nuclear imaging test. So I think there are 3 or 4 hospitals in Dubai, and also Dubai Hospital itself, City Mediclinic Hospital, American Hospital, and Al Zahra, Sharjah. If I'm not missing out any other place, these are some of the places that have nuclear medicine departments, and they do the test there. There was another question, why do we ask for an early morning sample? Obviously, the urine has got time to concentrate and stagnate in the bladder, and that may help, may not be so relevant in infants who pass urine quite frequently through the night.
Dr. Kalpana, sorry.
Yes,
Sorry, carry on, please.
No, I was just going to pose a question to both of you.
One question is there, Dr. Kalpana, cystitis seen on ultrasound. I mean, should it be treated or not, just on ultrasound?
No, this is what has been brought forward in previous discussions also, that cystitis, when they say you have to see whether they have done it on full bladder, they are looking at the bladder wall thickness and commenting cystitis. Take everything with the clinical judgment. Are there symptoms? Why did you do ultrasound? What does the urine show? And the radiologist has to see the bladder when it is full and not when it is collapsed and the wall looks thick, which is not the correct indicator of cystitis.
Yeah, there are a couple of questions by Dr. Chandran, actually, Manu Chandran. One of the questions is, how much percentage of UTI is urine culture positive?
I don't understand the question. Unless urine culture is positive, I'm not going to call it UTI.
Exactly.
So,
yes. And his other question is, can we rule out urinary tract infection by a negative urine culture report?
Yes. So now these are the general rules, like we have to look at urine culture should be positive. I'm assuming these are patients who have not been previously treated with antibiotics. We are not halfway through the treatment and getting a urine culture negative, So if a patient comes to you the first time, you are going to look at the urine routine. If you have done the dipstick analysis, look at the leukocyte estrus and nitrite test, look for pyuria and urine culture. So everything goes hand hand in hand, provided the patient is clinically symptomatic, because otherwise we are looking at asymptomatic bacteriuria. So
Yeah, that's
I think
Dr. Kalpana. You mentioned each
I
and
can't.
every urine culture positive means it might be contamination. Hello?
Yes, yes.
Hello?
You're cutting off,
Yeah.
Dr. Diari.
Hello, you can hear me.
Your voice is
Whether
very...
it is properly collected.
Hello?
First and foremost, the collection is most important. So as I said, we started with the emphasis on urine collection, and we are ending with emphasis again on a proper urine collection. Yeah. So you were talking about contamination, doctor.
Yeah, Dr. Diari, please.
Yeah, hello? You can hear me?
Yes, doctor.
Hello?
Yes, yes.
Yeah. Urine, not each and every urine culture positive means UTI. We have to, as Dr. Kalpana mentioned, we have to combine it with the clinical picture of the patient, because it might be just contamination or asymptomatic bacteriuria when you do the culture. So not each and every urine culture should be treated.
Yes, I second that actually, especially if there is no pyuria. If there is no pyuria and the culture is positive and the child is asymptomatic, I wouldn't treat at all.
True. Doctor, one very important subset is voiding dysfunction. So I just would like to know the surgeon's approach to voiding dysfunction. We get these children who are either having overactive bladders or lazy bladders, or who have a discoordinated detrusor sphincter dyssynergia. So how do you approach these cases?
Dr. Diari?
Yeah, avoiding dysfunction, really, it is a big topic. And we have many cases of avoiding dysfunction. Usually they are in girls, and usually between 6 and 8, 9 years. Most of them having a problem of constipation, and they are infrequent urinators. They are not going to the toilet, and they have a special maneuver, squatting the legs or crossing the legs. These are, they might have what's called symptomatic vascular-ureteric reflux. And when you are examining them, they have repeated UTIs mainly. And most of the time, these patients needs bladder diary, and we are doing for them urodynamic to see if they are overactive bladder or not, and then to be treated accordingly. And most of the time, you have to treat their constipation and to make them a regular toilet train every 3 to 4 or 2 to 3 hours to empty their bladder.
Yes, so
They are really difficult. They are really difficult to be managed.
Yes.
Really difficult.
Yeah, and sometimes we do use anticholinergics.
Yes, sure.
Yeah.
So maintaining a voiding diary really helps in the OPD. We must ask, we must spend the time with the parents, explain to them what exactly we want. We can advise Kegel exercises other than treatment of constipation. And some centers have biofeedback, which they use to retrain this. Basically, it all comes down to bladder retraining, apart from the use of either anticholinergics or alpha blockers, as the case may demand. So it's a very important subset, of course, it's relevant to this topic. So I thought I would bring it up. And the approach to treatment of VUR, what is the role of using bulking agents? Which cases you use bulking agents? Which cases you go for reimplantation?
Yeah, so usually vascular-ureteric reflux as the classification grade 1 to grade 5. Usually grade 1, 2, and 3. 1 and 2, most of the time, they don't need even antibiotic prophylaxis. Sometimes if there is recurrent UTI grade 2 and grade 3, we are using the deflux injection, subureteric injection. grade 4 and 5. Grade 4, maybe 50% or more than 50%, there will be successful, but grade 5, for sure, they need reimplantation and surgery. There is one question from Dr. Rasha regarding what recommended length for using prophylaxis, antibiotic prophylaxis. If it is indicated, there is prophylaxis. If it is indicated until the toilet training, we are using them. And it is not for lifelong.
Actually, quite a few of the reflux dies down naturally as the child grows. So earlier, even if it was being used for lower grade reflux, it was thought that by the time the child is 5 years of age, there will be a natural resolution. So those recommendations no longer hold true.
Yeah, most of the time it is up to 1 year they will be,
yes.
Then you will reassess them. And there was a very nice paper just published in April 2020 in Journal of Pediatric Nephrology. If anyone's like, I will put it in the group. It is very, very nice regarding vesicular reflux. And if it is needed to be diagnosed or not, and if it is the cause of the scarring or not. So I will put it on the group to be read. It is very nice, just up to date paper.
Sure, doctor, we'll appreciate that.
Yeah.
And about hydronephrosis, a lot of nowadays we get a lot of cases of antenatally diagnosed hydronephrosis because obviously, little bit dilatation also gets reported. And these babies are then followed up for a long term. So what is your experience now for them? Like, how do you decide which cases require more frequent follow-up or, go for further imaging or do some intervention?
Yes. As you just mentioned, antenatal hydronephrosis is almost about 5% of the pregnancies. They have an antenatal hydronephrosis, and most of these will be resolved. Those who have been delivered with hydronephrosis, then we have to follow. It depends on the unilateral or bilateral. It depends if the ureter is seen, the size of the bladder, and sometimes the keyhole sign, if it is of posterior urethral valve or not. So if usually we are not doing the ultrasound after delivery in the first 1 to 2, 3 days because of the physiological dehydration. And then in the first week, 3 to 7 days, we will do 1 repeat ultrasound. Then at that time, you will see if it is remaining or not. In our hospital, the guidelines, if there is any hydronephrosis with hydroureter, then MCUG should be done within 2 to 3 weeks. Then after that, by 1 month, we will do the isotope scan, and then accordingly, we will decide if it is a reflux or it is an obstruction, like that.
Right.
Yeah. Actually, the initial assessment of the child, of the newborn, will dictate how the newborn will be followed up. That's, yeah, and the initial assessment, as Dr. Diari mentioned, by repeating ultrasound, not immediately after birth, wait for a few days. You may wait even for 1 week and then do it. That's if there is no evidence of posterior urethral valve. Because if it is a posterior urethral valve, that's we have to deal with it in a different way and manage it in a different way by catheterization, avulsion, and all the rest of the. And as I said, the follow-up later on depends and is dictated by the initial assessment of the hydronephrosis.
Right. So which of the urological anomalies will require intervention in the newborn period? One of them you mentioned is it depends on PU valves.
Yes.
The presentation, I mean, of course.
Yeah, if it is, if the cause of the uropathy or hydronephrosis or is posterior urethral valve, yes, they do need early intervention. I mean, actually, the cases that need immediate intervention in the neonatal period are very, very, very few. And I think Dr. Diari agrees with me on that.
Right.
Very few.
Okay. There's another point which I didn't touch upon is the use of radionuclide cystography. A lot has been said about whether that should replace BCUG, whether it can replace. So just like we do the radionuclide DMSA scan, this is a radionuclide cystography. Now, obviously, it is thought that it does not give us the anatomical pictures required. It does not tell us about the micturating phase. So what is your opinion? Maybe as a follow-up, can it be used like you have a case of EUR and you want to follow up, but they don't want to go for an MCUG? Would you still advise this?
Yes, we have in Latifa Hospital for the last 1 year, we are using that one. But actually, we are, as a surgeon, we are a little bit reluctant because all our experience is with the MCUG.
MCUG.
And this is now good for the radiologists. But just as you mentioned, it is not giving the anatomical part of it. Again, we are using it now in combined in order just for the radiologists and for us to be more familiar with it. We are using both because it is, but it is less radiation. This is the only goal we are getting. There is no radiation in this one, but for sure, for follow-up is very good. For follow-up is very good.
So that's what we used to do. That for follow-up, we would recommend.
And I share that paper with all the group now. Huh? You can check.
Thank you, doctor. We will.
Dr. Sami George, one of our senior pediatricians, has asked, please comment on triple voiding exercise and your opinion on blueberry ingestion. Yes, especially
so double voiding and triple voiding has classically been advised in cases of VUR. It was thought that after they have emptied the bladder, some amount of urine may still go up and come back after a while. So these children were told that when you finish voiding, please wait in the toilet for some more minutes, and if you feel like voiding again, so that this is done to avoid any stagnation of urine. So double voiding, triple voiding, the proper positioning, though it may sound very basic, but sometimes the children do not separate their legs apart properly. Even that in literature has been described that they have to be taught to do these things, especially in cases of reflux, it was advised.
And the problem with compliance as well, and to get a child of 3 years or 4 years old to do this is extremely difficult, I suppose, particularly in toddlers. I mean, in older children you may be able to, but even older children, 7, 8, 9, the compliance is very, very difficult, actually.
And in girls, there is a concept of a bit of urine. There's something called as vaginal voiding, a little bit of urine that remains, and she should wait there and pass that bit as well before coming out. So
how much it helps. Use of urine bag, which is collected, do routine and rest for culture. What is the latest on this? Because the question was on that.
Yeah, urine bag is collection is not recommended for culture. The doctor has actually, I think he means that the other tests can still be done, and for culture it should be. But the problem here is that getting that one urine sample also is very difficult. So I prefer to give the proper, spend that extra 5 minutes in the outpatient, explain it properly to the parents that it's very important to get a proper report, and go in for a non-bag collection. If you just can't find it, just can't have it and you need it, and you've done a bag sample, if it is negative, then it tells you that there's no UTI. However, if it is positive, you cannot rely upon that. As far as the rest of the tests are concerned, as long as it is tested immediately, I suppose it can give us some idea.
Since we have surgeons in the panel, those questions related to surgery, because many surgeons are also watching our webinar. So please raise
there is a doctor Sunil. He wrote a question. Incidentally noted duplex kidney after first episode of simple UTI responded to antibiotics in older children. Needs further evaluation. Now he mentioned older children. Older children, I assume that is more than 1-2 years. So when there is a UTI and there is a duplex kidney, if he is young child, then we will go for the next step, ultrasound. For sure, he did the ultrasound. For that, he found the duplex. So we will go for the MCUG. But if he's older child, then we will not use the MCUG. Then we are going for the DMSA. If in the DMSA there is no scar, then we are not worried about reflux in this case. He is older, his kidney is mature, so we are not. But if there is a kidney scar, then we have to do the MCUG to evaluate the degree of reflux. For sure that patient will have a reflux if he is having a scar kidney. But if he is a small child, months, then we have to do for the MCUG first.
Yeah, just one more comment. I want to comment on circumcision and UTI. Once a child develops UTI, if they are not circumcised, I think they're strongly recommended. Circumcision is strongly recommended in those children, particularly in infants.
Okay.
Yes.
There was, they have asked about empiric use of antibiotics if UTI is suspected. I cannot emphasize it more here that unless we prove it, we should not be starting the treatment, except in cases where the clinical suspicion is really high, and children are unstable or children are, sick. Yes, you will start antibiotics. Which one you will start? Empirically, it is a cephalosporin group, which is across the studies has been thought to be the empirical first-line treatment that is used depending on the patient's condition, of course, whether it is oral or IV, whether it's an outpatient treatment or inpatient treatment. Yeah. So
any broad spectrum antibiotics will do, actually. Amoxicillin, claviolinate, or cephalosporins, or any broad spectrum antibiotic will do. But I mean, most infections are by E. coli. If you give something to treat E. coli, you will be right in 80% of cases, probably.
One of the interesting things that I came across while looking at antibiotics use and antimicrobial resistance, some of the countries can go to the extent of banning a particular class of antibiotics completely for over a year. They say, don't use it for a year, let the sensitivity return. So overuse of a single class is also sometimes, it results in.
Yes,
absolutely.
In every hospital, there should be a guidelines for restriction of antibiotics. And one of these antibiotics are the quinolones, and one of these are the some of the cephalosporins. You have to restrict them, otherwise the risk of UTI will be very high. And the ESBL. Now you mentioned ESBL 12%. In any single hospital now you are doing it almost about 50. 12%. You are very, very.
You're breaking up, Dr. Diaz.
The figure 12% is very, very low.
You're breaking up.
The figure will vary, I suppose, from place to place. ESBL is on the rise. But apart from that, we now have even carbapenem resistant cases. So, that is another thing to be taken care of. I think we need to have a separate discussion on antimicrobial resistance and judicious use of antibiotics. That's very important in today's day.
One question Dr. Khalid has asked, what is the rationale of using low-dose amoxicillin for prophylaxis as it may lead to developmental resistance? I mean, what is your opinion? Low-dose amoxicillin.
There's another question of low-dose amoxicillin. Amoxicillin is a medicine used for neonates and paraneonates. If we need to use antibiotic prophylaxis, that's a preferred drug to be used. No, and the prophylactic dose is always low dose. Sorry, doctor?
When you are using low dose, resistance may develop.
Prophylaxis per se has been associated with the increased antimicrobial resistance that has been proven now, and hence the recent guidelines recommend that we should use it only in higher grade refluxes or selective use in those cases of severe hydronephrosis. So we are trying to move away from a routine antibiotic prophylaxis use in each and every case as we used to do in the past. So I think the resistance rates are there. However, this is again a controversial area, and there's a lot of debate going on. Still more studies planned to see whether that's that's an adequate strategy. Because even if we go by the AAP guidelines of ultrasound, for the first febrile UTI, it is said that it misses 24% of cases of VUR. Now, whether those VUR cases, if we had picked up and put them on prophylaxis, would it prevent a renal scar or not? It's a very big question mark, but it does miss. So some practitioners actually recommend that this decision should be taken after counseling with the parents, explaining to them that your child can still have a second febrile UTI, and then when we go ahead and do the testing, we might find VUR and we might give treatment accordingly. So there is they should be made aware of the possibilities.
You will find that all in this new literature, which I send it now. You will find everything about that, about do we have to use the medication, or do you have to do the MCUG to rule out this group of patients. Yeah.
There was a question, the presence of only ketone in the urine, 2+, 3+. It has happened to us also. They call from the lab 3+ ketone, nothing else. How you deal with this?
Most often than not, it is due to either starvation or vomiting in these cases. Even severe exercise has been associated with it. So if we have to look at it in the clinical scenario. So it's generally these children are not taking feeds, they are vomiting, and then there will be ketonuria, obviously. If we are not dealing with hyperglycemia and glycosuria.
Okay, there is one question actually. Use of alkalinizing medicine if urine is acidic.
We went over it, doctor.
Yeah,
right. Sorry, I must have missed that.
So I think
the majority of questions are covered in the talk.
Yeah.
And somebody has written that the fosfomycin above 12 years. And, Dr. Kalpana, you can just discuss with Dr. Diari and Dr. Jundi those parts which are really, I mean, a dilemma, whether surgeon interferes or not interfere, what to do. I mean, this is a panel we rarely get. Dr. Diari and Dr. Jundi here.
Doctor, I come from an institute where our nephrology OPD was running in parallel with the pediatric urology OPD. So any case that, it was always a joint consultation, and I still believe in that. And I cannot overemphasize, because their approach and their inputs are equally important, or sometimes more important than what we can do. So I think that is to be kept in mind. If Dr. Diari or Dr. Jundi have anything to add, more than welcome.
Maybe I will add 2 comments.
What do you see in day-to-day? What cases would you think are mismanaged by us?
Yeah, please don't do too many urine routines, please. This is a trend every time coming, they are doing. And the other thing you mentioned, don't treat asymptomatic bacteriuria. Actually, we are treating asymptomatic bacteriuria in pregnant ladies and in kids which they are going for surgery, I mean for endoscopy.
Those are special situations.
So these situations, asymptomatic bacteriuria, you have to treat. The other thing, when there is an uncomplicated lower urinary tract infection with ESBL, please don't jump to, as you mentioned, to carbapenem. Please, still there is, as Dr. Jundi mentioned, 80% of the UTI, lower UTI, they are E. coli. Even if they are ESBL, they are sensitive to augmentin because of the clavulanic acid. And if you are admitting, we are using a very good, in uncomplicated UTI, you can use still tazocine or piperacillin, it can be used. Don't jump to carbapenem, to meropenem. Yes. Yeah.
Sure.
Yep.
In fact, I think every hospital ID committee is has to be strict about that. The indications for use of these restricted antibiotics, because unless until there is a regular check kept on that, just because the child's fever is not subsiding, or we don't have a focus of infection, we start escalating the antibiotic. That is, I think that's a trend that will put us more in trouble.
You are right.
Okay.
Yep. Any more questions? Any? More comments?
I think we have answered almost all the questions. Now, if we will see if any question is not covered, we can discuss it in the WhatsApp group. Because most of the things I see, it was discussed with Dr. Kalpana and explained by our pediatric surgeons. We will find and see if any question is left, we will answer in the WhatsApp, and we will request Dr. Diari also to post that important articles.
He has
I
already posted, I
already.
believe.
Yeah.
Already posted.
Now, I would like to thank our viewers for joining us tonight. I would like to thank Dr. Kalpana for excellent presentation. I would like to thank Dr. Diari, Dr. Jundi, Dr. Joshi couldn't join us. I would like to thank Mr. Tawfiq for hosting this. I want to give announcement after that. Mr. Tawfiq, you want to say something? Say at the end, I will give announcement, please.
Okay, so I would like to make the raffle draw.
Yes, you make raffle draw, then I'll do announcement. Yes, yes, please.
Okay, so I will take the first name now. Okay, it's rolling. The first winner is Dr. Mesaf Abdul Razak.
Congratulations. Let us see he's there or not. If he's not there, we won't give.
Okay, we'll pick the second one. So, second is Jacqueline C. Arrieta. Jacqueline C. Arrieta. Okay, so this is the second. I'll make the third.
Putting something in the chat or something, they are present or not. If they are not present, we won't give them. Dr. Diari and Dr. Jundi will take along with Dr. Kalpana.
Okay, I will make the last and the final one now. Third one. Second. Yeah. Hussein Naji.
Wow,
Dr. Naji.
From Parkview Hospital. Congratulations, Dr. Naji. See?
Okay. So,
See there.
so thank you very much. So before Dr. Sohrab closes, I will just give a word of thanks. So I'd like to thank all the delegates who have come online tonight for our wonderful webinar. And I'd like to thank Dr. Kalpana for this beautiful talk she has presented today. And I extend my hearty thanks to Dr. Sohrab and the DPC committee for partnering with New Country Healthcare for such scientific activities. And my hearty thanks to our panelists today unite, like Dr. Diari, Dr. Ayman, and even Dr. Joshi couldn't join us. The program is accredited with 2 CME points. Inshallah, within couple of days, you will receive one link for like a post-webinar questionnaire. Please do answer those questions so that you can claim your certificates. And until then, like, goodbye, stay safe. Assalamu alaikum wa rahmatullahi wa barakatuh.
I'd like to give announcement. Well, we will have our next webinar on Friday, 30th October at 7. It's regarding the vaccine. We will have our next webinar in November 3rd. Dr. Loy 8, consultant pediatric nephrologist, will be talking on different types of rickets. We will have a webinar on allergy, asthma, and our speaker is Dr. Hannan Sharif from Sharjah University. It will be on 6th Friday. On 28th November, we have our annual conference in the form of webinar. It will be a very big virtual conference with CME from morning till evening, with full of activities and prizes. So once again, I would like to thank our viewers from all over the world. We had 2,400 some registration. It was amazing because of Dr. Kalpana and our panelists. So once again, I would like to thank our panelists, also Dr. Kalpana, Dr. Diari, Dr. Jundi, Mr. Tawfiq for hosting this webinar. Dr. Joshi could not join us, unfortunately. So once again, thank you very much and good night. See you on Friday, 30th for our next webinar on vaccine. Good night.
Good night.
Thank you, Doctor.
Good night, everyone. Thank you very much, all.
Thank you very much. Good night, Doctor.
Oh,